Hello, everyone, and welcome to Wellness Live. We are so happy you have joined us today. My name is Esmeralda Valluru, and I'm a wellness dietitian in the Living Whole Wellness Program, and I will be your host today, filling in for Dr. Olivia Moses. This broadcast is brought to you by Loma University's Health Living Whole Wellness Program. If you are joining us via Facebook, YouTube, or on our website, please be sure to type in your questions for our expert today. Are you or someone in your life suffering from back pain? Pain is an unpleasant feeling that lets you know that something may be wrong. Today we have a special guest with us to talk to us about pain management and treatment options. His name is Dr. Eugene Pak, and he's an assistant professor for the School of Medicine. He is a physician for the Department of Physical Medicine and Rehabilitation at the Center for Pain Management here at Loma University Health, and we are so happy to have him here with us today. So without further ado, I would like to welcome Dr. Eugene Pak.
Hi, good evening. So today my topic is lower back pain. Pain itself in some ways does tell you something wrong is going on, but in many ways pain can be a benefit. Why do we have pain in the first place? We put our hand on the stove, but certainly I want to feel that pain to bring it away. With that said though, when you have pain that persists, when you are trying to do normal activities, when you know what is going on and the concerns are understood and you're still feeling that pain, this is something that could really change what you do on a daily basis, your emotions, and we're going to discuss lower back pain in a couple areas. We're going to go through a brief history of back pain. How did we look upon back pain over the past few thousand years, briefly? Thereafter, we're going to talk about what we call the epidemiology. Who gets back pain? What age? What does it cause to our public, to ourselves? Thereafter, talk about the actual anatomy. Where is the back pain from? Is it just from one spot more than another? What are the causes of this back pain? Thereafter, talk about how we go about finding why you have this back pain. What do we do to diagnose? Thereafter, we're going to have a brief break period. I encourage you guys to get some questions and queries in via either Facebook or YouTube so that we can answer those. And then after that, I'm going to talk about management of back pain, what options do we have, and preventative means too. So moving forward to 1600 BC, I have here the Edwin Smith Papyrus. And this is the oldest known surgical treatise on trauma. 48 cases of injuries and fractures and wounds were mentioned on this papyrus, but of interest, even way back in 1600 BC, they described a diagnostic test and treatment options for back pain. Moving ahead here to 400 BC, Hippocrates would discuss terms such as lower back pain, or sciatic pain, that pain from your back down your leg. And moving to the 500 to 1500 AD, during the medieval ages, the medieval folk would actually have various practitioners trying to treat these bad spirits. Mention of also watchful waiting to see if the back pain will get better, something that you and I have probably done over the past too. I have back pain, let's try this, I hope it gets better tomorrow. Watchful waiting to see if we could get better on its own with time. Into the 1920s, about 100 years ago, Dr. Harvey Cushing mentioned that there's an increased acceptance of actually surgically treating this lower back pain, such that by 1938, Dr. Mixter and Barr, orthopedic surgeons, published cases on where they would actually have back pain improved with surgical means. So back surgery has been something that's been around for almost 100 years at this point. So moving forward to who gets back pain. How many people get back pain? What, is this something that I'm the only one? Is this so uncommon? Not quite. As we look here, not quite uncommon. At this time, up to 80% of all people at some point in their lives have had back pain. 4 out of 5 people. And with that said, about 1 out of 10 people at this time on this earth, 1 out of 10 people are suffering back pain today as we speak. With that said, what ages does it begin? You know, I didn't have back pain when I was a teenager, elementary school, and usually back pain starts around ages 20 to 40, and it becomes more common as we age, ages 40 to 80. And this is something that's not gender specific. It's not just men or women. Both men and women seem to have it rather equally. Moving forward from here, talking about back pain in the US, is back pain something that stops us? Is this something that causes disability? Disability such that we cannot work. disabilities such that we cannot socialize with family members, go to church, go to our groceries. And out of all the disabilities, be it depression, migraines, various diseases, various organ diseases, lower back and neck pain is the #1 cause of disability in the US right now. This is the #1 concern. And this is something that certainly likely resonates either with yourself or people that you know, family members or friends. And with that said, it's the most common concern as far as the musculoskeletal complaint in emergency rooms. And for people who are working, ages 20 to 40 or even past, about half the people who are missing work is usually due to back pain, more than these other causes, be it the flu or other reasons. But for longer-term disability, back pain causes disability to up to 40% of people. So what is back pain? How is it just pain in my back, or is it what causes it? What are the basic concerns that we have with back pain? And when I think about back pain, we have thoughts about back pain worsening in this area of the back, worsening with movements, be it lifting, twisting, bending, sitting too long, or standing. You may have pain that actually shoots down the leg. When we have numbness and tingling, this might be a sign that you have a pinched nerve in the back, causing pain that radiates down the leg, or perhaps the arms from your neck. And when you have back pain, this is not just, I have back pain, I'm suffering right now. This is back pain, and I'm having problems with my sleep due to the back pain. I'm having problems with depression and anxiety. There was a study out there on chronic back pain, and in patients and people with more than 3 months of back pain, 1 out of 2 people have clinical depression. And when I mention clinical depression, this is something where you're not eating as well. You're not enjoying things that you normally do on a daily basis. You're crying, you're tearful. And if you think about that, this is a disability that's not only stopping us, but this is something that's actually causing us great demise as far as our emotions and the way we interact with other people. So what common concerns do you have with back pain? What conditions? And this is not a catch-all for everything, but certainly obesity, stress, and when I say stress, I mean psychological stress. And it's a bit of a catch-22. You may have psychological stress from having back pain, and then the stress that you have itself can cause more back pain. It's a circuit that kind of continues and feeds into itself. Poor posture. You may be sitting there at home right now. If you could look into the mirror, how are you sitting? Are you sitting down with a lower catch on your back? Are you resting on your shoulders? Is your neck slumped down? Or are you actually bringing your back up? Are your shoulders back? Does it feel unnatural to sit up like this or to stand like this? Pregnancy, certainly. During pregnancy, patients get more back pain during this period of time as well. Deconditioning. I used to exercise quite a bit in my teen years. I don't have time to exercise anymore. I certainly get enough exercise at work. I go from my car to the grocery to my workplace and back. But certainly deconditioning in that if you don't have a regular routine, be it 20 minutes of some type of exercise, those type of patients will have more back pain. And also, how are you sleeping? Poor sleeping positions can also cause worsening back pain over time. So a busy slide here, but I'm going to distill it for you. The concerns are, well, what kind of causes cause the back pain? What can it be? Is it simply a muscle? Is it cancer? What's the thought process here? And I basically look at back pain into 4 different categories. The most common, of course, is what we call muscle, skeletal, mechanical pain, be it from the spine, be it from the muscles and the hips, the most common type of pain. Other types of pain that are not as common are inflammatory pain, be it you having rheumatoid arthritis, ankylosing spondylitis, be it a cancer, various red flags that come out with cancer, be it a family history of cancer, be it loss of weight, pain that comes on suddenly that you can't sleep with, and also infection. The spine itself can also have infections. You can have an abscess in the spine. And some red flags that come to my mind are fever, other recent infection that was partially treated, but now you're having this new back pain, and some thoughts to come about to make sure that you don't have. What structures are affected here? As you can see on the slide here, everyone's seen a skeleton model in the past, whether you see the human skeleton model, the dinosaur model at the museum, and certainly there's different structures that can be affected, starting with the disc and the areas between each level of the vertebra. But not only this, it's not always a pinched nerve, it's not always a slip disc. It could also be areas where the nerves themselves are irritated, be it the joints on the back of the spine as well, which when you push back, the joints themselves can cause back pain. Muscles, it could be more simply muscular pain over time, not simply the spine itself, and be it even claudication from blood vessels. So certainly when I think about back pain, it's not all simply that disc, and many patients can have on an image a slipped disc, an area where the disc is outpouching, but the pain may not necessarily come from that slipped disc. There was a Mayo Clinic study done years ago on patients in the military with no neck or back pain, and they did MRIs on all these patients with no neck or back pain, and a good percentage of these patients in the study actually had a number of slipped discs, be it large, be it small, but they were asymptomatic. So I wouldn't let that disc itself, that abnormality, fool you into saying that's 100% the reason for the back pain. The bigger deal would be is to consider where exactly is that coming from your symptoms and your exam. So when we talk about what's causing this back pain, certainly if you were to have back pain in the past, this is something that's on your mind. You're saying, I'm having back pain. I want to know what I can do to get better. And the first step to do is actually not just say, I'm going to change what I do on a daily basis. I have to ask myself, where is the pain generator? Where is this pain coming from? Be it the disc, be it the joint, be it the muscle, be it something catastrophic that is surprising, something rare. And when we do this, if you were to see your nurse practitioner, your family practice doc, you see myself, considerations go into the clinical history, what are the symptoms, and the physical examination, various maneuvers that we can use just in the office to see where we think it comes from more often. And when I think about back pain, I always try to look for what we call red flags. What's dangerous? What makes me say this might be something more than your common variety back pain from mechanical injury or mechanical changes, be it weakness, a fever or infection, a previous history or family history of cancer, be it unintentional weight loss makes me consider cancer again, be it loss of bowel or bladder control. Is there something affecting the nerves or my spinal cord? And moving forward, I'd have to say not all patients, many patients will not need imaging. But certainly if there are these red flags, persistent pain that makes you surprised or concerned, something more apoplectic, fever, loss of weight, history of cancer, an X-ray is a nice quick imaging after a trauma to make sure there's no major fracture of the bones, no major dislocation. A CT and an MRI can take a nice three-dimensional look at the spine to take a better look at the nerves and the structures. And also, if it seems like there's a specific nerve damaged and you're having specific weakness in one location, you can do an EMG, which is a nerve study, to test the muscles and their function to see if it's something more acute. One thing I got to pause on, though, with imaging is that, again, like I mentioned with the Mayo Clinic study, I wouldn't simply focus on only this is the image and this is what I exactly have. Really, the bigger deal for me always is I do pay attention to imaging if it's obtained before I see a patient, but the clinical history, what symptoms are you having? How long have you had it? Where do you have this pain? What positions make it better or worse? What have you already done to make it better or worse? And also the physical examination, be it various maneuvers. Maybe the back pain is not from a pinched nerve in the back. Maybe it's from your hip joint. Maybe it's from walking a little bit abnormally. So there are certainly a number of considerations that come into play that make me state, you might have an image of a slipped disc like this here, but I wouldn't simply focus on that. But certainly an image can help. So we're a few minutes into our talk at this time, and at this time we'd like to have some discussions. Have there been any questions?
Yes, great. Thank you, Dr. Pak. I found myself readjusting my posture in the middle of your presentation.
Myself too, while I was standing.
Great. So we did get a couple of questions in, and the first one that I have here for you is pain different depending on the condition?
Certainly pain is different depending on the condition, and it's different but sometimes similar. Whether it be a new pain that you're having, with fever and difficulty sleeping at night, those kind of pains make me worry more. If it's something that's keeping you up, something that's really new that you've never had, you can't think of the injury. You think of something more concerning that imaging may be considered. Other pains you might have had for a long period of time that are pretty well patterned, something that you're used to having, something that, if I sit like this is what happens, really speaks to me being more of a musculoskeletal pain. With that said, it's tough to say. It depends on what your clinical history and exam shows still.
Got it.
And thank you for the question.
Great, thank you. So we have another one here for you is, do I need a referral to make an appointment at the Center for Pain Management here at Loma Linda?
And that's a good question for me as a physician. Many times I'm not as cued into how to make referrals or how appointments are made. But I do think the first step would be is to go ahead and make a phone call or make an email to the center and to see from there. It sometimes depends on various insurances. But with that said, yeah, if there's a concern you're suffering right now, this is something affecting you on a daily basis. The interesting thing is also, if you're having back pain, you look in the mirror, family members look at you. You can't even see the pain that you're having. And you even wonder to yourself, is this real pain? Is this in my head? And to which I say, certainly it is. You're feeling back pain, your head's perceiving it. And if you're suffering, certainly you can call the office here, you can ask your primary provider. Some patients need referrals, some don't. But be sure to call. If you're not sure, go ahead and call either us or whoever else your provider is, wherever you're at too, whether you're in the Loma Linda system or not. I think it makes sense to at least pay attention to this and treat yourself. Yeah.
Great, thank you so much. So we have one last one here for now, and we want to invite our viewers to make sure that you're typing in your questions. For our expert, we will have another opportunity at the end, so feel free to type those in, whether you're tuning in via Facebook, YouTube, or on our website. So the last question here for now is, what can I do to avoid becoming addicted to opioid painkillers?
Sure, and it's no easy answer to that. I was going to talk a little bit about that in my second section here, and I have a whole talk on that itself. Addicted is a tough word, and I'd like to say that whether you are or are not stuck on this pill that you feel that you need, you're not a bad person for that. That's what I got to really say straight out, and your providers who have prescribed that to you are not either. With that said, if you're talking about painkillers like hydrocodone and Percocet, about 10, 15 years ago, the whole talk is that it's really okay. But the more data that comes back here is that it actually works on certain receptors that cause a great physical dependency. And what can you do? Studies that I've seen is that if you've been on a narcotic for 7 days straight, there's about a 10% chance that you'll be on it for 1 year. If you're on it for 1 month straight, there's a good 30 to 40% chance you'll be on it for a year. And when you're on it for a year because you need it, perhaps you could call it an addiction, perhaps you call it a dependency and a need. But if there's a medication that does that to you, that's very concerning. What can you do then? I didn't answer your question quite yet, and what you can do is try to look at other options, which we're going to go into the next few slides here. What other options do we have? And you might say, you got to be, wow, I mean, I've tried that before. I've done that. But many times, if you're off of the narcotic for a period of time and your body readjusts to not being on it, that itself is part of the battle to kind of try to stay away from it. But what can you do? You can try your best, discuss with your primary provider, discuss with your family and friends. One of the major things is to make sure that you're not a bad person for being on that. Don't start making it personal that you are. The addiction word is very inflammatory in some ways, and I want to really stress that point here, and I hope that helps you. And I hope that helps answer the question in a little bit of a securious way.
Yes,
yeah.
No, I like that. Great, thank you. That's such a great reminder right now, and we'd like to get back to your presentation. Thank you.
Sure. Some of the questions that were asked will be answered here in the next few slides. The slides are a little bit busy, but I want to talk about something I ask every intern or medical student who rotates through the pain center when they're rotating on in our clinic. What is the definition of pain? And answers always become, well, pain is just pain. But what is the definition of pain? Pain is, of course, an unpleasant feeling of tissue being damaged, something being hurt, be it a knife in my hand, my back bones rubbing each other, arthritic. But pain is also, the definition itself is also the fear of this pain itself. If I have the fear of the back pain getting worse tomorrow, that is pain. What is my number of pain? Is it a 1? Is it a 10? The number that you have is exactly what you think it is. It is not up to me to tell you what that number is. If you feel that your pain is severe, it is a severe pain. It is not just all in your head and you're overdoing it. You're overthinking things. Your pain is what you're experiencing, and I think that all should be respected. And by the definition alone, pain itself is in your head. Because how do we feel pain? Pain comes from nerves that detect pain, be it a thermal receptor or chemical receptor damage, transmitting discomfort up the nerves into the spinal cord, into the brain, and I perceive it by two pathways, be it an emotional deep pathway and the actual sensation pathway. And when you have pain, it always hits that emotional pathway as well. And then also the inhibition, your body, your brain trying to inhibit that sensation. So when you think about this when you have, if you may have stomach poisoning, that's another kind of pain, right, from food poisoning, right? You have tears that come out when you have this pain. It's an emotional response. So you're not tearful that you ate a bad burger, but you're tearful because of this pain. It's not just because you're crying because you're hurting. The actual pain pathway causes you to be tearful and fearful and sad. So pain is this all together, this circuit here. And when you think about treating the circuit, we think about a number of options, and I like this slide. It discusses not just the physical pain sensation, but really when I see a patient, I always think about what challenges do they have at work? What daily activity issues do they have at home, family and friends? If someone sees me in clinic, another clinic patient, right? But this is somebody who's actually taking out the time because they suffered so much to see the physician. Depression, anxiety. Again, if you've had back pain for more than 3 months, there's a good chance you have depression, anxiety. It's not your fault. This is part of the process. This is part of how pain works. And sleep disturbances. So of interest, the better you sleep, the less pain one has. But how are you going to sleep if you have back pain? And then you have something where you're not sleeping well because of this back pain, causing you a cycle of having less sleep, more back pain, worsening sleep, more anxiety, depression. You can't function normally. And what options do we have? I'm going to go through these options in the next few slides, many of which you've already tried before. But in some ways, I'd like to open your mind to saying, what about trying again? Or what about therapies that have been out there? What do the studies, the literature, and research say? And keep in mind, if I did the same treatment for the same type of pain for 5 different people, that same treatment may well work for you, but not me. So I have to respect that everyone reacts differently to these different treatments. But this is at least the general gestalt that we have. Really, really makes sense on physical therapy and management. What do we do physically? Increased physical activity and exercise is the number one, as far as our research shows, of what can try to mitigate, decrease the pain that you have. Walking can help for acute pain to an extent, chronic pain not as well. Heat therapy can help for acute pain when you have it immediately, not chronically. Heat and cold, actually chronically, there's little evidence for benefit for chronic pain. Yoga, some benefit. Swimming. The TENS unit, that little electrical unit for your back, is a temporary benefit, but not really beneficial for long-term benefit. Ultrasound therapy, also lumbar traction devices, where you're having someone laying down, stretching them, or you're actually trying to lay down or stretch yourself from the ceiling. At least as far as science says right now, there's not much evidence for benefit of lumbar traction. What about some alternative medicines? And me as a medical physician, I may not have studied acupuncture, chiropractic care, these other means, various herbs and other means, but certainly these may benefit you as long as you research and make sure it's being done safely. But as far as the data shows, behavioral therapy, CBT, cognitive behavioral therapy, where, and you're probably thinking, that's really mind over matter. You're telling me not to think about the pain, identifying what the pain is, and correct my negative thinking. And certainly, though, that, at least as far as our research shows, has really benefited people, one of the best means, by trying to help you try to not think about the pain. I have pain, how do I not think about it? And there are means by which you could see a neuropsychiatrist and cognitive behavioral therapist to benefit you, modifying your thoughts, your emotions, and behaviors for this pain. Chiropractic care, mixed results. Acupuncture, some studies do show that it does give some temporary benefit, long-term not as much. Massage therapy certainly can give short-term benefit, not long-term. What else? Medications. And as a physician, I find it very easy to prescribe a medication. It's something that I'm licensed to do. But it's not our only treatment. Remember, there's the various physical therapies, the alternative medicines. And certainly, but medications, how do I look at medications? What can be used? And when I think about it, as a medical scientist and a physician, I don't look at it as one medication for all, but I do know what is less concerning as far as side effects goes, what can be more beneficial and less depending on the patient. Anti-inflammatories such as ibuprofen and such can benefit. Muscle relaxants, and not all muscle relaxants are the same. Muscle relaxants, for me, I try to think of different receptors. This baclofen works at GABA B, this tizanidine works at alpha 2, and if one doesn't work, maybe a different may. Opioids. Of interest, opioids are beneficial for back pain in the short run. The long run, there are concerns. Concerns of not just the addiction, but certainly there are studies that show that if you've been on narcotics a long period of time, you will need more to match the same benefit that you had initially. What else? There are some studies showing that you have a higher chance of osteoporosis, your bones breaking down over time, on chronic opioids. It does something what we call decreasing osteoblastic activity. What else? It actually decreases hormonal levels of estrogen, DHEAS, testosterone, causing more fatigue. And then you have this whole chronic fatigue. You're on opioids. You had back pain. Then you're sluggish. You're not sleeping well. Do I have fibromyalgia or is it my back pain? It becomes this whole milieu for some patients. And of interest, the CDC in 2016 mentioned that narcotics are not a preferred treatment for chronic pain. Antidepressants, I'm not depressed, but certainly Cymbalta and some of these medications can help benefit by increasing certain receptors, certain chemicals such as norepinephrine, which help for pain. And also anti-seizure type medications. I don't have seizures. Why this? Gabapentin Lyrica can benefit pain for some patients by working at a voltage-gated calcium channel as a blocker. So when I think of this, I'm not mentioning these terms to seem fancy. I'm saying these receptors I'm looking at and thinking about that when I'm talking to you as to what can work. Of interest here, there's how many patients are needed to treat in narcotic-naive patients for various types of pain. Ibuprofen and Tylenol actually have had a higher chance of benefit than oxycodone, which seems to be pretty equal to some of the antidepressants, but not the gabapentins and the Lyricas not as good as the ones above. So something to think about. Now, again, these are different people are affected in certain manners, so this might not be you, but certainly the first go-to would be ibuprofen and Tylenol, as well publicized as it is. Other treatment options, another passive treatment that we do, but it's really not for everybody, are injections. Can an injection get you out of the cycle of pain, trying to break this pain cycle? Can we go directly there? Moreover, it could be a diagnostic stating, is your sacroiliac joint the cause of your pain? If we put a needle there, put steroids there, can that benefit you? If it doesn't, certainly though, if these injections do not benefit you, certainly it's not something that you want to keep doing. Certainly steroids have their concerns. There is a risk with every procedure that we do. But if it can benefit you, and you can have these procedures in very minor amounts, not very often, it is an option that you have. Some thoughts here of spinal cord stimulator, where you can put small leads into the middle of the spine to decrease your perception of pain, can benefit some patients with what we call failed back syndrome, post-surgical back pain. Intrathecal pumps, I was just talking with somebody just a moment ago about placing a pain pump, a catheter into the spine, giving narcotics. And different discussions out there, but nowadays we really like to reserve this more for cancer pain. If it's more young person chronic back pain, the issue I have is that the intrathecal pump will help, this narcotic pump will help for a period of time, but you may gain some resistance to what its effect is. And the studies definitely show that an intrathecal pump into your spine does not keep you from taking oral narcotics. This is not the cure-all against that. And if you're going to have a pump placed, or you already have one at this time, don't be dismayed. Your physician, your provider will still try to help you, but certainly consider your other options, other medications, other therapies if you can. Consider your social options. Who is helping me socially? Can I talk to somebody about this? Consider your depression. Are you depressed from this back pain? If you are, it's not your fault. It's okay. We have means to try to help you and discuss it too. Last slide here on therapies, and then one last slide on what we can prevent, includes surgery. I'm not a surgeon, but certainly we have various neurosurgeons and orthopedic surgeons here at Loma Linda that can help. The main three surgeries for causes of back pain and structural changes include a discectomy, where you're trying to relieve that little piece of disc that may be pinching on the nerve. Mind you, a lot of these discussions come into after the physical exam, after the clinical history, after imaging, of course. If the structure is off balance and causing pain, the spinal fusion can help fuse the vertebrae together. if your spine, especially for older patients, is squeezing the nerves, you can actually do a laminectomy, taking a piece of bone and lamina off to reopen that area up. And certainly this is something, like I mentioned in the early part of the discussion, we've been doing for almost 100 years now. Last slide here, before further discussion and questions, and feel free to write more questions as we move forward. What can we do to prevent pain? And it just seems like a catch-22. I've got back pain, I can't exercise, but somehow, some way, if you can get some degree of exercise, 20 minutes on a regular basis, bringing up your heart rate, even if it's not specifically for the back, studies have shown rather consistently that this can help, and this has helped a good majority of patients for back pain. What else? Mattresses is actually something I thought about when I was making this talk just a few weeks ago. What kind of mattress should I have? And I looked through studies. Very firm mattresses are actually not good. Soft mattresses, of course, no good. But what about medium to firm mattresses? Also, how are you sleeping? Do you have other children or dogs in your bed, and are you sleeping to one side? Try to keep that bed clear. Proper posture when sitting and standing, again, like we have here. Even when sitting, it seems abnormal, but try to bring your back up. If you're driving a car, maybe get a small lumbar pillow for your back. It doesn't have to be a fancy pillow from Amazon or something. It could be just a pillow you have from home. A small little pillow to keep your back propped up when you're driving long distances, especially what we do in traffic here in California too. Proper lifting techniques, not lifting with your back like this, but try to bring your knees down and lift as such. What about back belts? I need this back belt on a regular basis. Now, if you're not status post-surgery recently or recent fracture of the back, I really would bet against using a back belt. The back belt may feel good when you're using it to an extent, but it will also decondition you, make you weaker, and definitely cause more pain over time. Lastly, also shoe insoles, something I've been asked on occasion, shoe insole for back pain. Unless you're having significantly asymmetric legs, shoe insoles have not necessarily benefited for back pain. So were there any other questions?
Yes,
Sure.
We unfortunately don't have enough time for all of the questions, but we do have one from Donald, who is tuning in via Facebook. And he describes himself as a 60-70-year-old and overweight who is experiencing lower back pain on both sides, with it getting worse as time goes on. And he's currently treating it with naproxen and meloxicam.
Anti-inflammatories, right?
Every few days, or when he knows that he'll be doing something heavy.
Sure.
Is that kind of frequency okay? That's what he's asking.
Yeah, that frequency I think is reasonable. And every provider might have a little bit of a different swing on it. Now, certainly if you're taking naproxen, which is a similar type of medication as the meloxicam, I wouldn't necessarily take them together. Both are about once or twice a day medications. But I think certainly you can take that. I think that's reasonable. I would not take it together with ibuprofen, which is similar. Concerns of stomach upset, kidney damage as well if you overtake these medications. But while you're doing that, I say it, why not think about how we're sleeping in bed, how we're driving in the car? Why not think about how we're sitting and eating dinner? Even get a small mirror, or ask a family member, how do I look when I'm sitting? And sit up there, bring your arms back, and if it feels abnormal, and for most people it will, even for me too, I always have to remind myself, sitting up. But try to do that, and I think at first, your back pain will worsen to some degree, because it's an unnatural position you haven't done for a while. But I think over time, that will really get you in a better place.
Great. Well, thank you so much. That was a wonderful recommendation. And so we want to thank our audience and, of course, Dr. Eugene Pak for being here with us and providing us with this valuable presentation. And on behalf of the Living Whole Wellness Program, we would like to thank you for joining us. And we want to invite you to next month's Wellness Live by Dr. Brian Bull, who will be talking about your gut and you, rethinking the science of nutrition. See you then.